This is being provided for by the Louisiana Department of Health and Behavioral Health and the LCPR. Again, thank you, Dr. Tolbert, Dr. Harrison, Paula. Thank you so much for your great leadership. I wanted to provide an opportunity for the LCPR to provide a bit of a welcome and to share with us the reason why this training is important and what they hope you all will be able to get, and the reason why they have invited you all to participate. And so with that, I believe, Dr. Tolbert, I'm coming to you. Is that right? Is it you?
Yes.
Okay, very good. So
Yeah.
Dr. Tolbert, thank you so much. The floor is yours.
Okay. Well, good morning, everyone. Thank you all so much for registering for this training. We are looking forward to the great information that Carlton Hall Consulting, as well as Dr. Hunt, will be giving us, dealing with promoting health equity and trauma-informed services. We have more sessions to offer as well. So you all will get an opportunity to hear more and more about the prevention work and to include in your repertoire for the prevention work here in the state of Louisiana. I am the executive director of the Louisiana Center for Prevention Services, and you can find out more information about what we do with the center as far as the training and resources that we provide through our website. And Paula Carrera is our program coordinator, and she will give you all the website in which you can find that information. Paula? You're muted, Paula. You're muted.
I'm muted. Thank you,
Yes.
Dr. Tolbert. Our information, you can visit us at www.subr.edu/LCPR. That's our website. You can reach us through the email at lcpr@subr.edu. Thank you, Dr. Tolbert.
Thank you. And once again, welcome, and I will turn it back over to Carlton Hall.
Thank you both so very, very much. And we will make sure that we provide that website information in the chat for those of you who weren't able to capture that immediately. I want to just offer our thanks to everyone for this, but also a bit of a disclaimer. So we're going to be recording this session today so that you all might be able to have access, and for those members of your coalitions and teams who would want to participate and learn from the webinar today, you'll be able to access that later on. I am kind of obligated to share that the opinions, that the comments, that the information that is provided, while some of this is supported potentially through funding from SAMHSA and other federal agencies, the views expressed are our own. And so I wanted to just go ahead. Everybody is off the hook now, so no one has to worry about that. I simply want to share with you that the reason why this is, I think, one of the most important conversations that we can have today, along with those things that we're going to be discussing and having the opportunity to discuss with you in future trainings, is because there is indeed a priority that's set by the state. And I have been really grateful for the in-depth conversations and all the work that has been done by Drs. Tolbert and Drs. Harrison and Paula and Amber Slater from the state in thinking about what's important for each and every one of you as you are developing your capacity. And so in that view, we have developed a series, and I am grateful to be able to provide for you all a series of trainings that's intended to do just that, much of which can be utilized for those of you who are seeking certification and the like. All these trainings can be aligned towards that pursuit, but I will talk more depth about that when we come to the end of this training today and before we close it out, so that you can have that information as well. I want to start off because what we're going to do is we're going to engage everyone. Hopefully, this is going to be an interactive session for you all. So I want to start off with a little bit of a game, if you don't mind, and hopefully you all have options for the chat. And Dave, do we have the chat set up, and are they available for the chat?
Yes, indeed. A few of y'all have already been popping in there as well.
Fantastic, fantastic. So here's what I want to do. I want you all to look at this, and if this was an actual shirt, right? If this was an actual shirt, how many holes do you see? Just quickly put that in the chat if you wouldn't mind. Go ahead and do that if you wouldn't mind. Just put that in the chat.
6, 2, 6, 6, 6, 2, 8. Another 6.
Got it.
Keep them coming.
Got it. How many holes do you see in the shirt? 6, 2, 8. Fantastic. Fantastic. All right. So let me stop you all now. Stop you all now. And I'm not quite sure if we're all looking at the exact same shirt, but if we are, here's what I'm gonna share with you. The answer is actually 8. The answer is 8. I will go through that really quickly. If this was an actual shirt and you were looking at the front of this shirt, you're seeing a hole in the front and a hole in the back here. So that's 2. There's another hole in the front and a hole in the back. That's 4. You have a hole for your head to go through and a hole down here for your body. Many people miss that. And then of course, 2 more for your sleeves, for your arms to go through, which is a total of 8. All right, why did I do that? I did that because there is a saying that we have a lot of times in our communities. And that saying is quite simply that you can't appropriately solve a problem unless you can first appropriately see that problem. And in many respects, that's what today's training is really about. As preventionists, we are all being charged with, challenged to raise the level of our execution, to understand the important needs that our communities are requiring of us. And some of those are issues and needs and challenges that may not be as apparent as they might be or ought to be, or as others are. And so we're challenged to see some things that are sometimes a little more difficult to see. So while you all may be applying for grants such as juvenile justice grants, or the Drug-Free Communities Support Program grant, which I know many of you are participating in, or even the Strategic Prevention Framework Partnerships for Success grants. All of these are federal opportunities for us to execute prevention science well on behalf of the communities that we serve. They are requiring us to think a little bit differently about, and to help our communities to think a little bit differently about how we approach prevention on behalf of our communities. And in today's world, and with respect to the work that you all are doing, you have a remarkable ally in your state that is geared toward doing just that. The LCPR is providing training content and partnering with us to provide you with some exclusive training content that is intended to build those capacities for you and for your teams to participate in. And so you'll get more information about this as we go further into the conversation. But I want to start off with a quick question in reference to what we may or may not be seeing as a way of setting this up. As you all might understand, we all have been challenged by the pandemic and by our responses to the pandemic. And what has happened during this pandemic is that it has put a bit of a spotlight on challenges that we all have to be attentive to. The challenges of disparities that are evident in our communities, and how are we responsive to those disparities? We were dealing with an opioid crisis before the pandemic came about us, but this pandemic has now put a spotlight that there are indeed even deeper seated challenges that we have to be mindful of. For example, what we aren't seeing is the fact that in our general population across the country, access to substance misuse treatment is only being accessed half as much by communities of color than they are by the overall population. Now, those are things that oftentimes go unnoticed and unaddressed, but we are being challenged within the scope of our work and our efforts of how do we address that? How can we think about that? How can we look towards those issues and those challenges in a better way? And so for this training, what we're going to do is we're going to engage in that conversation. This training is intended to provide an opportunity for us to think about the work that we do through the lens of prevention slightly differently. How does it relate? How does it affect? And how is it affected by issues of being trauma informed and looking at disparities in the way we might be able to address those disparities? And with that, I am remarkably blessed to have a fantastic team that's helping to support the training today. What we are going to do today will involve my good friend Dave Clausen. Dave Clausen, who you all have heard from already, is supporting me. Dave Clausen is the Center Director for the Mid-America Prevention Technology Transfer Center and is a remarkable national prevention leader in his own right. He is supporting us here in the support of the technology, supporting us through the chat. He will be engaging with you all through the chat. So we are encouraging all of you to put your comments, to comment on the things that you're hearing through the chat, we're going to solicit questions from you and comments from you all throughout the training delivery today. In addition to Dave, and we're thankful that you're here, Dave, thank you so very, very much. In addition to Dave, we're going to have the opportunity to work with a remarkable expert who is going to actually talk to us about a lot of what's going on in our nations, throughout our nation. In fact, the Substance Abuse and Mental Health Services Administration, SAMHSA, has really begun to challenge all of us within the prevention field to think about these issues in a more concrete way. Why? Because what they've discovered in a recent report that they have released is that there are indeed existing impediments to many within those communities that make them more vulnerable to the kinds of behavioral health problems that many of us are here to address. And so in order to speak to that and to speak to that well, I have solicited the help of my dear friend and an extraordinary national leader in her own right. Dr. Cerise Hunt is the Associate Dean of Diversity, Equity, and Inclusion for the Center for Public Health Practice and the Department of Community and Behavioral Health at Colorado School of Public Health and the University of Colorado. She is responsible for leading the school's efforts in advancing diversity, equity, and inclusion excellence. She is responsible for forming community linkages that guide public health practices throughout the state. And she is well versed in our work in prevention and has helped me to think differently about the way we link the needs of diverse communities with the prevention efforts and work that we're doing. And so with that, I want to turn the floor over to my dear friend, Dr. Cerise Hunt, allow her to say any more that she would like to say about herself and take us into this training. After she speaks, we're going to have a bit of a question and answer period. So we'll have a bit of time to interact and we look forward to that. So with that nothing further needing to be said, Cerise, I'm turning it over to you. Thank you so much for being with us.
Thank you all. Good morning, everyone. I'm so happy to be here. And as I'm preparing my slides, One of the things that I'll share with you all is I started, my career started, although I'm in public health, my career started as a caseworker for Denver Department of Human Services in the Child Welfare Division, specifically working with substance abusing mothers. So substance abuse prevention, family preservation was where I started my career back in the 90s. So it's a near and dear area that I address. And what I'm going to talk about, it's all connected together. And so I'm excited to be here today. As I'm talking today, one of the key things that I want you to think about is how does this inform my work? When we're talking about, well, what is my role in advancing equity? Because we all have a role in promoting equity. We are influencers in all of our rights. So I want you all to think as we begin talking and having this conversation is thinking about, okay, what is my specific role? What can I do to ensure that I'm not perpetuating inequities? And so we're going to talk about all that today. You got to have the direction that we're going. We're going to review, because I'm hearing a lot of terms. We're going to talk about health disparities, social determinants of health, and then we're going to talk about health inequities. And then we're going to make these connections to explain factors in the social environment that can contribute or impede the health of individuals and communities. And then we're going to identify trauma-informed prevention strategies that meet the needs, of the individuals that you're serving. So it's really going to say, how do we inform this? How do we ensure, how do we take this work and make sure that it meets the needs of underrepresented? So as I'm talking, who in your communities are underrepresented? You know your regions, you know your communities way better. And as I'm talking, who's underrepresented and who's underserved in your communities? And when we're talking about underrepresented and underserved, then what the question is why are these individuals underrepresented or underserved? And so I like definitions. It just ensures that we're all speaking the same. Becoming a trauma-informed practice, a program, organization, or system that is trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system. And when we use this term system, what I want you to remember is that we make up the system. Sometimes we want to point our fingers in different directions, but it's people that make up the system. And responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So what's key about this is you want to integrate trauma-informed practice in your policies, procedures, in everything you do. It should change your behavior as well. And so Healthy People 2020, now you do know there is a Healthy People 2030, but I still like this definition of health disparities because it gets to some of the, Carlton was talking about the, COVID-19, but there are some realities, even the pre-pandemic realities that we're seeing within a lot of the families that we're serving, the communities that we serve. But health disparities is type of difference in health that is closely linked with social or economic disadvantage. That's that underrepresented, under-resourced, underserved communities. And it negatively affects groups of people who have systematically experienced greater social or economic obstacles to health. So we're going to be talking about barriers. There's barriers to health that create these, what I'm going to call inequities. And obstacles stem from characteristics historically linked to discrimination or exclusion. What's critical when you're engaging with your families, if teens, and even when you're engaging with teens, you're dealing with the whole family. History, we have to know the historical context of the communities that we're serving, because there's a history that is linked to discrimination or exclusion based on one's race, ethnicity, religion, socioeconomic status, gender identity, sexual orientation, geographic location. So if you're in a rural population, health, when we're talking about access to services, access to care, rural geography matters. One's ability, and then one's mental health. And then, so then we know that there's behavior health disparities, refers to differences in outcomes and access to services related to mental health and substance misuse, which are experienced by groups based on their social, racial, ethnic, and economic status. So we're seeing differences. And as I'm talking, there's some common themes around these differences, racial and ethnic differences, social, economic. The first health disparities report, since we are talking about history, I'm going to go off on a little bit of tangent, but it'll be a quick tangent. The first health disparities report was written in the early 1900s by W.E.B. Du Bois in the Philadelphia Negro. He took as a sociologist, he took a cohort of Black folks and tracked their health. And what's interesting is some of the same health issues we see today. So when we think about history and health and wellness, there's a long history that even in the early 1900s that are relevant to today. So then I got a poll question because I want to make sure y'all engaged. So my poll question, I'll just read it to you before you're asked, to select, and you'll be given a prompt. Will free access to health and wellness care service eliminate these health disparities? And it's a simple yes and no. So we'll be ready for the poll. So you can select yes or no.
All right, they're coming in. They're coming in. And you just let me know when you want to end the poll, Cerise.
Okay, and we can go ahead and end. I think we have just about everyone. Okay, so as we look at the results, will free access, it looks like the majority, we have 83% said no, and we have 17% said yes. And the correct answer is no. Because, and we're going to talk about that, because when it comes to health and wellness, it's not just one's health. What research has shown us is that people of color, and when I say people of color, I mean our Latino community, Hispanic community, our Native American, our indigenous population, our Asian Pacific Islander population, and our Black community, African American community, do not receive the same quality of care. There have been multiple studies that have shown, and it's usually due to the bias of the provider. So when we're talking about health and wellness, free access to care, yeah, it's great. I'm not saying that we shouldn't have free access to health and wellness service. That's not what I'm saying. But we must address the systemic issues within our organizations where folks aren't feeling that they're getting the same quality of care. And that's what we're going to talk about for the remainder of my discussion. Thank you all for participating in the poll. And so, as I stated, types of disparities. You have your health status. Your health status is just how you feel that day. Pain, comfort, yes or no. That's a type of disparity. But then types of disparities that are rooted in inequities. Access to care, as I stated, and quality of care. And it's looking at multiple variables. How accessible are the services? So that's what contributes to disparity. So if I live in a rural population and there's not a doctor in my region and I have to travel 20 miles to the nearest health facility, I've heard of that, where there's not an OBGYN in the community, you have to drive 20 miles. Well, that's an accessibility, because what happens if I don't have transportation? The accommodations, acceptability, affordability, can folks pay co-pays? So then we have folks that we talk about are underinsured in all those different areas. Realized access, there's folks that aren't aware of the service that they're available and that they're accessible to me, and the availability. And so what this contributes is to, changing our conversation to just the differences, to really think about health inequities. Differences in health statuses are in the distribution of health resources between different population groups arising from social conditions in which people are born, grow, live, work, and age. They result from systemic, avoidable, and unjust. That's what's key. Systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. So it's barriers to the opportunity. We cannot blame the individual client, the individual person. We need to look at the systemic issues and really change our lens to the inequities that are contributing to the disparities. So I'm going to use COVID real quick as an example. We have high death rates of COVID-19 in our Latino community and the African-American Black community. We have high rates. It's not that the disease is chasing after these individual groups. No, we have to talk about who are the individuals that are essential workers, who are in harm's way in different areas. In addition to that, when we talk about pre-existing health conditions, we have high rates of cardiovascular disease, pulmonary disease in these groups as well too. So it's really thinking about how are individuals accessing the services, and then what conditions contribute to this. We still have a lot of folks that have a mistrust in health care systems due to treatment. So these are the systemic issues that occur. And so when we're thinking about one's health, I love this because it really gives you an opportunity to look at multiple things in regards to it's not just one's, because when we look at one's health, we look at genes and biology, and then we look at, health behaviors. Well, that only makes up 40% of our care, and actual clinical care. We also need to look at one's physical environment and social and economic factors. That makes up about half of one's health, in addition to the clinical care that they receive. So social and economic factors contribute to one's health, and we cannot deny that in these discussions. And so that's where we start talking about what we call those social determinants of health. And so you have the individual factors, health behaviors. Then you have provider factors, bias. We have a lot of bias. A lot of research has shown that bias of providers, bias in even pain assessment. There's a study that showed that that looked at providers not treating certain groups, like specifically in the Black community, African-American Black community, feeling that they had higher tolerance for pain. And there was a whole pain assessment. And these are those bias issues that we'll say that come up. And then also being able to not only address the cultural needs, but we have to address the linguistic needs. You all are, if you're receiving federal funds on your program, even if it gets kicked down to the state or kicked down to the university and then goes to, your program or your project, you are required by Title VI of the Civil Rights Act to not only address the cultural needs, but the linguistic needs of the individuals you serve. So that means we need to know the language. Our communities are changing. And I think, in my community, we have some groups from Burma, and they have 7 different languages that they speak. And it's our responsibility to address the linguistics. So knowing the linguistic needs of your communities is the role of the provider. If we want people to have access to our services, well, a huge barrier would be, well, if you can't communicate with me, then that can impede one's health. And then as we look at the health system, how it's organized, financed, delivered, that can create, that's a whole, and especially in our healthcare system, that's why we see programs like patient navigators that are helping people navigate different systems, community health workers. Those are those interventions that help people engage. But then we cannot, and I can't stress this even more, forget about the social and environmental factors. And remember from this slide, the social environmental factors count for 40% of one's health. So, and determines 40% of one's health. We have to look at poverty, education, proximity to care, and neighborhood safety. These all contribute to one's health. And I'm just going to show you this really quick because I don't want to spend too much time on this, but this is a model that we created that looks at health equity that kind of explains it and really breaks down how can we conceptualize the social determinants of health. Well, we have to look at individuals' health through a life course model, from pregnancy, early childhood, adolescence, adulthood, older adult. And you have to look at the social determinants of health. So you have the life course, social determinants of health, economic, income, one's built environment, accessibility to recreation, food, transportation, air quality, housing, all of that makes up for one's health, safety. And then the social factors are critical. Social support, participation in community, racism, is key. Racism impacts, there's a physiological aspect of racism. There has been increasing acceptance in medicine of the concept called weathering. And this was founded by Dr. Geronimus at the University of Michigan School of Public Health, which holds that the stress in living as a member of a community of color in itself takes a toll on the body. And so that means the experience of racism and discrimination, prolonged exposures to the indignities and dangers of discrimination, it weakens one's cardiovascular and immune system. All of this leads to accelerated deterioration of the body. And so that's what research is showing us. So when we think about one's health and wellness, we have to look at the social factors and how they are contributing to the health and wellness. If we look at the high rates of infant mortality among Black women, it's high. No matter when you control for socioeconomic status, we still have high rates of infant mortality, which is linked to stress and the impact of stress on one's body. So all of these social factors need to be contributed. And then you add this to health factors, one's conditions, whether nutrition, physical activity, mental health, access, utilization, and it equals population health outcomes. It explains quality of life, one's morbidity, mortality, and life expectancy overall. So all of these factors are critical. And so then the whole community, ACEs study, the adverse childhood experience, was expanded to community trauma, the impact of chronic adversity across a community from factors related to structural violence, inequitable economic opportunities, deteriorated physical environments, inequitable policing, whether it's under or over policing. I could probably sit here and talk a whole hour on policing. Inequitable access to quality of education, healthcare, transportation, and recreation. This all equates into one's health and contributes to that area. And so with that being said, just to do a quick summation of what I've covered, Dr. Kamara Jones explains the cliff of good health analogy, and we're going to watch a quick video. And so Dave, if you could go ahead and start the video for us, please.
I'm Dr. Kamara Phyllis Jones, past president of the American Public Health Association. You may have heard the saying, an ounce of prevention is worth a pound of cure. When it comes to health and well-being, preserving health is always best. But there's more to the story. Imagine that someone is walking along and whoops, they have just fallen off the cliff of good health. And if that were you, you'd be relieved to find an ambulance at the bottom to speed you on to health care. But what else can we do to protect you? How about a net to catch people? But nets have holes, so some people may still fall through, and the net is likely to rip over time. What else can we do? Clearly, we need to build a fence at the top of the cliff to keep people from falling in the first place. But if a lot of people are near the edge of the cliff, even a really strong fence will not be enough. To keep everyone safe, we need to move all the people away from the edge of the cliff. We do that by addressing the drivers of poor health that go beyond our genes and beyond our personal behaviors. Things like low wages and under-resourced schools and unsafe housing. The environments in which we live, work, and play shape our health. These are the social determinants of health. These things can either propel people toward the cliff's edge or keep them at a safe distance from it. But this cliff analogy is incomplete. We need to also realize that the cliff is really three-dimensional. And then, to notice that resources and people are not evenly distributed along this cliff. At some parts of the cliff, the ambulance at the bottom may have a flat tire. Or maybe there's no ambulance there at all. Maybe there's no net, nor fence. And usually, at those parts of the cliff, the people are being pushed closer to the edge. These are the differences that lead to health disparities in a population. Differences in the speed and quality of the ambulances represent differences in quality of care. Differences in the presence of ambulances, nets, or fences, these represent differences in access to care. And differences in the distance to the edge of the cliff represent differences in the opportunities and exposures and stressors that make some people and communities sicker than others. We need to ask a lot of questions. Why is the cliff three-dimensional? Why do some parts of the cliff lack ambulances or nets or fences? And why are some people being pushed closer to the edge? It's because our economic system fails to provide an even playing field. It's because racism, which is foundational to our nation's history, is still with us and continues to cause profound harm to us all. And because discrimination against people of color, women, immigrants, the LGBTQ community, poor people, and others holds back our nation's health and well-being. Everyone should have the opportunity to achieve good health. If we try to address the social determinants of health without tackling these bigger systems of structured inequity like racism and sexism, we risk moving some people away from the cliff's edge, but not others. We risk making health disparities worse. Experts at the Urban Institute are exploring how local, state, and national policies have gotten us to this point, and what policy solutions inside and outside the healthcare system can drive fundamental improvements in health and well-being for everyone. We can all play a role. We can support our kids' teachers. We can participate in neighborhood cleanups. We can volunteer with community organizations. And let's recognize and dismantle racism, sexism, and the other big systems that assign value and structure opportunity in ways that undermine some groups more than others but hurt us all. Doing so will radically improve health and well-being for everyone by creating the conditions all of us need to have the best health possible.
So that's just a summation of really looking at this, how these systems are in place and they're structuring opportunities for individuals to engage, and really that explanation. So as we continue to move forward, I want to talk about the health outcomes in Louisiana because it's important that you all, and you may be aware of this as well too, but as I'm talking about the health and wellness, I was like, oh, I was interested to try to find out what was going on. And there's the differences in health measures among counties and for racial and ethnic groups as well. And so they listed, the data is listed, and I got this from the 2019 county health rankings. And I would encourage you to really engage and have an understanding, if you don't have it already, of this data. But what is our data telling us? And as stated in the video, the why behind it. So there's a comparison of the healthiest counties, the least healthy, and then the breakdown by Asian American, American Indian, Alaska Native, Asian Pacific Islander, Black community. So when we're looking at premature death, you have high rates in your Black community. Also looking in white, Hispanic and white as well too, but you can see the difference, higher rates within our Black community. Then as we're looking at other data sets, we're looking at poor or fair health across the board as well too. And so that's the breakdown of the data from that I was able to see. So I'm just wanted to give you an idea of the trends of health and wellness. So I won't spend a lot of time, but these were where I saw the difference, health outcomes in Louisiana. Looking at American Indian and Alaska Natives are most similar in health to those living in the healthiest quartile. So you have the healthiest quartile, and then you can see the Black group, the Black community are most similar in health to those living in the least healthy quartile. So breaking it down, and you can see the breakdown among populations and groups. So this is just giving you an idea of those disparities, those differences within Louisiana. Severe housing cost burden. And so when we're looking at housing in Louisiana, 14% of households spend more than half of their income on housing costs. So remember, that was one of the social determinants of health across Louisiana counties. Housing cost burdens range from 3% to 26% of the household. And so when we're talking about the housing burden, once again, you're seeing some common themes among certain groups and certain populations as well too. And so then the question is why within those areas as well. Children in poverty was another area from the county health rankings. They are looking at different areas. We see high rates within our Black, within Hispanic, and our American Indian population. So we're seeing, but you're seeing some of the worst outcomes of children in poverty. And then I did the housing. And then I looked at the teen birth rate in Louisiana. Now, as I was looking at this data, this had a 10-year, and this is from the Annie Casey Foundation, the Kids Count data system. And what you see is over the years, the rates of teen pregnancy went down. And so you have the number of live births to women ages 15 to 19. So this is the top line of number. And then the number of live births to women age 15 to 19 per 1,000 females is the bottom. So you're looking at more of the percentage rate and what's the percentage breakdown of that area. But as you can see, it's gone down. And so then the question, if the data set goes down to, well, what was occurring in this time frame? I know in Colorado, our rates went down because of there was a whole free contraceptive movement that went on through Colorado. Now, I don't know if that was the same. I didn't have time to dig into the data to get the why, but those are the things that you all should understand too, is, okay, how were they going down? What was working? But in addition to this, I don't have the racial and ethnic breakdown of this data as well too, to see if there's differences even among groups as we're looking at teen birth weights. Then when we looked at LGBT, this is more national data because I wanted to just make sure that I looked at the data around our LGBT population. because I want the groups that are experiencing some of the inequities. LGBTQ individuals are more likely than twice as likely as heterosexual men and women to have a mental health disorder in their lifetime. LGBT individuals are 2.5 times more likely to experience depression, anxiety, and substance misuse compared with heterosexual. And so there's a lot of stigma too of engaging in health and wellness care within our LGBTQ population. So ensuring that there's access to care. And then if we talk about teens in this area too, you know, what services are available and how are they being addressed? And are they provided in a way that individuals feel safe, that they can come out and share their story as well too. And then rural populations. This is more of a national data and looking at rural populations and methamphetamine. And so I just want you all to know that when we look at health and wellness, it's important that you have an understanding specific, and I saw that come up in the chat, what is going on at the different parishes, what is the health trends, what are some of the resources. Really having that breakdown is critical in really knowing the health and wellness and combat, and as a strategy to combat the inequities that we're seeing. And so here's the information for our rural populations. Accessibility is key. Lack of options for specialty substance abuse treatment programs. We heard about that at the beginning. So accessibility is key for folks in rural populations. So then the barriers to care is lack of awareness about available resources, stigma associated with mental illness, distrust of health and wellness systems. I mean, and you know, there's a lot of research that I was reading a study recently that looked at Black women and physicians and providers not believing their story. Like, you know, not, you know, this whole idea like Black women don't know their health, don't know their body in those different areas. And so we've seen that within different systems. I mean, Serena Williams, you know, she had shared her story when she was delivering her child. So there's a lot of bias and mistrust for, you know, for different groups at the hands of providers. Lack of providers from diverse racial and ethnic backgrounds. I think that is key to this conversation. We need more providers of color in all areas, in all clinical substance abuse counselors in all different areas. Lack of culturally and linguistic competent providers. Like I said before, it's not just addressing the cultural needs, addressing the linguistic needs. Economic barriers, and many LGBTQ people have reported experience stigma and discrimination when accessing health services. So when we're, you know, a lot of our programs talk about, we're about equity, we're about advancing equity, but if you haven't addressed these areas, these concerns, are you truly valuing equity? And so I know I've kind of had a lot of hope and, you know, doom and gloom, the despair when we're looking at the harsh realities. I want to transition us to more of hope of what we want. And the hope is the advancement of health equity. Health equity is the assurance of the conditions for optimal health for all people. I have to stress all. That means everybody. That means, you know, individuals whose values are different than mine. We, you know, services. We want to make sure that we are addressing the needs, and we cannot have a one shoe size fits all approach to the way that we deliver care. So even as we engage with certain groups, you know, not what works for one Latino community may not work for another group. We even see health differences. Diabetes diagnosed Puerto Rican is going to be different from someone who is diagnosed as Mexican, you know, identifies as Mexican. So it's a different it's a different health and wellness with folks. And so we have to shift our thinking to this approach is going to work forever and have that checkbox approach. That's more of that checkbox mentality. Well, if it worked for this group, it's going to work for everyone. And as we can see throughout history, the needs of people of color are not being addressed. We have to do better. So achieving health equity requires valuing all individuals and populations equally. recognizing and rectifying historical injustices. We have to recognize and rectify historical injustice. You hear a lot of folks talking about dismantling structural racism. It's key. We do need to dismantle. These structures were not designed for folks of color. Our healthcare models, our prevention models were not in mind with people of color. So we need to change our way of thinking and rebuild. So we want to dismantle, and we don't want to rebuild the same way. We need to rebuild through an equity framework, through an equity lens that's looking at and that's going to rectify historical injustices. And then we got to provide, now this is the key, the equity conversation gets real when we start talking about providing resources according to need. And I'm going to talk about that in just a moment. So I'm going to put a pin right there, but that is the real equity. We need to provide resources according to the need. And health disparities will be eliminated when health equity is achieved. And I'm gonna come back to this because I've already alluded to this, and I want to go back. So I'll go back to that slide in just a moment. When we talk about health, this is from the Robert Wood Johnson. You know, equality. So you equality means everyone gets the same. So for this example, and I love this picture, the purpose, my program received funds to give everybody in the community a bike. And the whole goal is for people to have mobility through a bike. That is the whole point of the project. So an equality mindset will say, well, everyone has to have the same bike. So that's what we did. We took the grant funds and we ensured everybody got the same bike. But as you notice, if we look in this first area, this first bike, well, here's one of my community members. The bike didn't address their needs. And if I go to the next person, well, this bike is, this bike did not address. If we go to the next, this individual seems to be too big for the bike. Her bike, oh, well, this bike worked for this individual. There seems to be some mobility, some movement. But then the fourth bike that was given out did not work for this young person. It's too big. So only one person was able to get their needs met from this bike. My intent was good. So, the intent, my intent was to do good, but the impact, there's some unintentional consequences for community members, and their needs were not addressed. Equity says, well, you know what? We're going to find out the needs of our community members and allocate resources according to that need. So if we go to the equity area, the first bike, as you can see, probably costs more than the originally funded bike. So there was but now we have a community member that has some physical, mobility challenges, can now use a bike. Then for the second person, this bike is larger, address the needs. So I can imagine that this approach of equity, that everyone's needs are still being addressed, but some folks got additional resources to ensure that they had the mobility. And that's what the whole notion around equity is. We have to give people the services that they need according to through the individual needs. It's not just a one shoe size or one bike approach is going to work for everybody, because there's different folks in our communities that have different modality needs. And so that's just an example of providing resources according to need. And so the Louisiana Department of Health is dedicated into promoting health, and they have given up their plan, their health equity plan. And there's 5 priority areas. And I thought that this was really good. So they're looking at maternal child health in those, and they're framing it in the same discussion that we're having right now in their equity plan, and they're looking at the barriers to health and really having that discussion around ensuring that access to medical prevention and rehabilitative services for all citizens. and they recognize the shared barriers to health. That's the BTH is barriers to health. Poverty, lack of access to health care or insurance, poor communities, poor educational opportunity, racism, stigma, and then barriers to health, lack of stable housing. So this whole doing our work through an equity frame, through an equity lens and then there's a whole plan to how we can all work together and partnering. And so I just wanted to share that as I was going through, because it kind of it frames the discussion of what we're having right now. So partnering with your local departments of health and environments are key, because in order to promote equity, we're going to have to use a multi-systemic approach. If we're going to talk about addressing economic barriers, if we're going to address housing, that means we have to have the housing folks at the table. We have to have K through 12 educators along with higher ed, because we got to make sure if we're going to recruit and retain people of color, if there's an underrepresentation of people of color in prevention field, in health, in wellness, if we need to diversify, higher ed needs to be there, because we need to be talking about recruiting and retaining folks of color in these environments, in these work settings. We need to be we have to have our business community at the table, built environment folks, recreation center. All of these entities need to be, it's called health in all policies. That's the shift that we're making in public health. It's not just the public health people and the healthcare and all that. I mean, even as we're talking about addressing COVID-19, it's not just public health folks that are addressing COVID. It's gone through every arena. So we have to have a multi-systemic approach that is partnering, working in conjunction with neighborhoods, community, our faith community across the board to promote equity. And I've really jumped ahead, but I thought this was a very nice plan, and I'll share the links. So if we don't understand what provides for equity to begin with, we can't provide health. And so I'm going to make the transition from theory to practice. So now we've talked about what needs to be done. Now I want to quickly talk about, well, how does this apply to my practice? Because too often providers, practitioners use the language of social determinants of health and the need to reduce disparities, but do not internally transform in ways that allow for non-traditional actions. That's what's key, non-traditional actions required to address social injustice as a risk to the public's health. The major challenge is to move theoretical knowledge about the relationship of social injustice to increase health risk and poor health outcomes into broad, sustainable changes in agency policies and practice. We have to do our work better. And so that's why I'm glad to be here, to be a part of the discussion, because it's going to take all of us working together to really address these challenges and these injustices. So the strategies for advancing equity, this is our call to action. You really have to support equity as a value and a social right. And when I say equity, that means ensuring that you're allocating resources, you know, and ensuring that you're thinking of who's benefiting and who's not benefiting from your services and the why. Are there certain groups, because they're not benefiting your service, that you might need to allocate additional resources and funds towards? Strategies, another strategies is workforce development education. I can't not only for, so I'm glad to be in this session, to be a part of this series. You all are already doing the work, you're educating yourselves. It's a continual education. In addition to this, educating your policymakers, legislators, heads of organizations. They need to be a part of these educational discussions and sharing the data and the information. I've already talked about interagency, multidisciplinary coordination. We have to move outside our silos. We really have to break down the silos and make sure that as prevention folks, we're not just working with prevention folks, we're working with other community leaders, because we need to begin blending funding mechanisms. When you create and establish these funding mechanisms, I mean, if you establish these partnerships and these multidisciplinary coordination, you can also blend funding mechanisms. We have to partner and work with communities, really authentic community engagement, protect people from health problems and health hazards, give people information they need to act collectively in improving their own health. I am all about self-determination. Give people what they need, they can make the decisions on their own. We just had a whole town hall, well, it was a couple months ago, around the COVID vaccine. And it was a real talk town hall for Black and brown folks, where we just came in, a bunch of leaders that were, Black and brown came together and had a discussion, real candid conversation so people can make their own informed decision. We didn't say you have to do this and you have to do that and you provide the information and allow people to make the decision on their own. Also, in our workforce development training, I just want to talk about, make sure that you're also taking your own bias and implicit bias trainings and education. You should know your bias. I know my blind spots. I've done the work. I couldn't come before you all without doing the work, but I continually engage in bias trainings and assessments just to ensure that I'm aware of my bias and preconceived notions. So taking things like the implicit association test. Build alliances and coalitions, mobilizing. I started the Colorado Black Health Collaborative, and I started that in 2000, worked with leaders within the community, and it's a whole nonprofit organization. So mobilizing communities and coalitions is a great way to engage folk. Public policy development and analysis, really analyzing policies and analyzing it through an equity lens, advocacy, monitoring the health status. You should, like I said, what's our data telling us, and questioning the data, the why behind the data. So why, like I said before, why did we see a downfall? Because what was going on in that time frame was working, and we want to continue to build upon that. And then track the conditions that influence issues facing the community. And then another area, as I'm seriously wrapping up right now, is examine your practice through an equity lens. Central questions to help design new programs and policies. These are the questions that you should ask yourself when you're thinking of a new program, policies, or process. Who determines what the decision-making environment looks like? Think of physical space, but also meeting structure, frequency. Have all decision makers taken a few of the project implicit tests, so the bias test individually? How will affected communities be involved in defining outcomes and success? As someone who I work for a university. I can, it'd be easy for me to define outcomes and success outside a community, but true partnership should be in conjunction with community. Have you used a variety of data sources, including both quantitative, because the quantitative is good. I appreciate quantitative, but the qualitative data can try to get you to the stories behind the data. We need both data sets hand in hand, quantitative and qualitative, to identify the most affected communities. And then what communities should be given priority, what communities will not be able to benefit, and why? And will a mechanism exist for affected communities? This is a kicker right here, to hold decision makers accountable. Who holds you accountable in your interventions? I have a whole equity committee that holds me accountable. And this committee was formed before we even designed our Equity, Diversity, and Inclusion Center. We brought this board together, and they hold us accountable. And it's thought leaders from across the nation and folks from the community that can hold us accountable. So, how are you being held accountable? And really, as you can see, equity is ensuring that we are sharing power. I don't believe in empowering communities, because communities have the power. So it's not that, it's just giving folks the opportunity to authentically engage in our efforts. And even having community members at the table, is there a shared power? Is there a shared, in having that being constructed? And how will you communicate results back to all affected communities? And then, as you can see, including the communities who were not able to benefit. So sharing your data, sharing your outcomes are key. That's truly doing your work through an equity lens. And you might decide that you need some assessments to really do this work. But this should be, so when you're designing a new program policies, that's how you can ensure these are the questions to ask yourself to ensure. And so doing equity work will cause you to have to pause. We can't just go our day to day. We have to stop and pause and ask these questions and ensure we're engaging authentically. And then there's a whole process that you can ask questions after you've implemented the program, policy, or process. So then you can share this. You know, how are communities benefiting? What communities are not able to benefit and why? Do the affected communities have power in the decision making? So it goes through the whole process for after you've implemented. So that's that accountability to what you said that you've done. This is the intentionality of doing equity work. When we're talking about dismantling our structures, we want to build with these types of questions that we're asking ourselves before we start any programs, before we implement, you know, and then after implementation as well too. And like I said, that requires that we do the work. So health equity exists when all people have the resources they need to maintain their health. And so instead of hoping that equity will be the result of our work, we must make it the core design principle of initiatives. So we're thinking through that equity lens, through that equity framework. It's not an afterthought. And we must be intentional about the advancement of equity. And I can't stress that it will not just happen. You know, we have to be intentional of taking the time to engage in trainings. We have to educate ourselves, and it's a continual journey. And then there's a list of resources that, that you'll have access to. That Kamara Jones Levels of Racism, I think that's a great resource. And that's it. And there's my contact information. But I believe we're going to open it up for Q&A. So thank you all for engaging. I'm sorry I can't see everyone, but thank you all for engaging in the discussion.
Dr. Hunt, thank you so very much. That was an extraordinary presentation. Thank you so very much. Full of rich information. There's already been some comments that expressed their appreciation and acknowledgement of a lot of the things that you shared and speaking with and speaking to that. Folks, I will let you know that in future sessions, we will be having it such that we will be able to kind of see everyone and work with respect to everyone. I also want to let you know that immediately after this session, Dave and I have worked out so that we will have a kind of an addendum, kind of an, because of who we are, we don't have after parties. All right, I'm not doing an after party, but we will have an after.
It's Friday.
An after training. I know it's Friday, right? After training for those of you who want to come over for a few moments. We're going to do the obligatory Zoom class photo, but we're also wanting to provide some opportunity for us to chat with each other, and you can chat with us and Dr. Hunt and the like. But right now there's questions, and so we want to ask some questions. And I was asking you all to put some in the chat. And so while you all were thinking about that, Dr. Hunt, I'll start off with a couple of my own to kind of have kind of stimulate the thinking around all of this. You had talked a good bit from the beginning about the importance of the physical environment and the social and economic environments and those impacts on behavioral health and on our health otherwise. And a good many of our coalitions often use addressing the physical environment as a direct strategy for addressing kind of population change. Can you talk a bit more about how our coalitions might be able to utilize that equity lens that you spoke about as they're thinking about their strategies and the strategies that they are using. I really love the idea of our ability to ask ourselves questions that would prompt us to think differently. So could you elaborate just a little bit more on that?
Yeah, I'd be happy to. So when we think about one's environment, and because you were mentioning the environment and the physical environment, one of the questions that I would ask are access to recreation centers. You really kind of breaking down community and social isolations and those different type of networks that, so, you know, if we're looking at a community, and in public health, we map this. So we are notorious for mapping. So we'll map all the recreation centers. We will map all the bike paths, because in certain communities, you know, we have, you know, you want to give out free bikes in a neighborhood and there's not a bike path you know, or none of the schools have bike racks. So we had a community. So, you know, I'm kind of being facetious, but the reason we track this is you might have a plan to give everyone a bike. I'm going to use that again, but there is not any lock areas. The schools didn't have lock areas. So everyone was, well, what are we going to do with the bike? Our folks didn't have helmets in those different areas. So the economic burden of, if there is a recreation center in one's community, what's the cost associated? Can the individual, so knowing the social economic status as it relates to accessibility to resources. I was working with a rural community and they said, well, Cerise, I was working at the state at the time. They said, Cerise, you know, we're going to start a walking group for the women in our community. I was like, okay, great. Well, I looked out the window, their community did not have sidewalks. And I was like, are they going to walk along the frontage road? So when we're looking at community safety, you know, light paths, good sidewalks, all of these things that we have to know for our own individual community. You can't frame it from your neighborhood. So I can't look at my neighborhood. I have to make sure that when I'm looking at the communities and I'm the individuals I'm serving, knowing the resources, the accessibility within one's neighborhood. In a rural community, you might not want to put your mental health center on Main Street. Because everyone would see me going in to get my behavior. There's stigma around behavior health. So and that came up with me on one of my projects. They were like, y'all got to get rid of it off of Main Street. I would go, but I don't want everyone in the community knowing my business. And so it's that little things that we have some really great intentions, but it creates some barriers, and that's how you can get. So that's the way I would address that. I hope that answers your question. It's really knowing that all that's going on with, know your community, know the social networks. You know, not everyone goes to church, so we can't say everyone goes to church. So what do you do for the unchurched folks that do not have that, you know? So yeah.
Absolutely. Folks, I'm still looking for you to put your questions in. One of the other things that really struck me is when you put up your your equation for how to achieve kind of equity at the population level. That was extraordinary for me, right? And so you talked about starting off with the life course, right?
Yes.
And understanding the importance of the life course, plus looking at understanding social determinants, and then those health factors to be able to reach that point of looking at population change. Communities, prevention coalitions are constantly looking at creating change at the population level. And one of the things that I like to share with coalitions and preventionists specifically is that for me, prevention is all about identifying those vulnerable and those who are the most vulnerable within our populations, and where and how they are vulnerable, and to be able to address those vulnerabilities throughout the lifespan of our society, right? And so we're looking at prenatal, we're looking at adolescence, we're looking at what's going on as they achieve and go into high school, we're looking at college age students, we're looking at adulthood and so on and so forth, with a variety of prevention. Could you talk a bit more about how we do that from an equity standpoint. And what I loved about what it was that you said is that we have to value all individuals equally. As we're doing that, we have to have a sense of recognizing the value of, of equity for these folks. How can we do a better job of that as we're thinking about our strategies?
I hate to sound, it's going to be knowing who you serve and the uniqueness of who you serve. And so taking the time to really engage community is going to be critical, especially if you want to take on that life course model in any type of intervention that you create. So if it's for young folks, as I'd have a coalition of young people, diverse, representative, and share with them, and engage them authentically. You should engage them in the planning of the whole process. That would be equity minded, that from the beginning. And in addition to that, if you're engaging community, you are compensating them for their time. Community people are the only people who are expected to work for free. And so if you are mobilizing community and everyone on this Zoom, if everyone's getting paid, but that one community person who's committed to their community, and you need to compensate them for their time and their dedication. That's equity. That's, you see the allocating of resources. So we would pay that person to participate. So we, in my center, we have a whole youth coalition that's doing, and they're all about social justice. They are compensated, they are paid. You would do it for every area. And so you could have a equity committee that has a makeup of different people, and that way, but they have the influence to connect to the community. That will ensure that your intervention is working. Also, keeping current on different ideas and plans. So if you're doing things like with us, we do preconception health, where we're trying to get women to think about pregnancy before. So we're going to work with college campuses. Now we need to be working in high school and middle school, but talking about being healthy and what does that mean? So it might even take us out of our comfort zone when I mentioned preconception health with middle school, and people were like, oh no, but if we want to talk about health and wellness in the long term. And so it's just making sure that you're culturally responsive to the individuals. What works for seniors is not going to work for another group.
Thank you very, very much for that. I would also encourage folks to check into looking at an implicit association test or some kind of test that you might be able to apply. That they're very easy to access, and you might consider having your coalitions go through that process. Understand this, everyone. All of our community and our prevention efforts and our coalition efforts are now being asked to think about these kinds of questions and how we're going to address and associate ourselves with addressing equity and looking out for those most vulnerable in our communities and our populations. And so we wanted to make sure that Dr. Hunt was our first speaker to be able to address that, to help us to think more broadly, possibly about some of the work that we're doing. And so we just want to give her a round of applause and thank her right now for a tremendous presentation. Thank you so very, very much. I want to ask Dave Clausen, if you wouldn't mind, in the chat, we're going to put a link, and that link, please take copy of that link. That link will take you to an evaluation for this course that we just conducted, and please feel free to do that. This link will be open, the evaluation will be open from now through next Wednesday. Next Wednesday, we are going to close it out. There's going to be a follow-up email that's going to come from either Paula or myself to each and every one of you for participating in this. And I'm about to let Paula share her closing thoughts with respect to all of this, but I wanted to make sure that you are aware of the evaluation that's so vitally important for our work and our efforts. What's next for us? This is a part of a series, and you all are going to receive. I'm so excited about this. I have great, great, great instructors lined up. I'll be providing some trainings as well. There is going to be an extraordinary opportunity for us to learn with and from each other. There will be a lot of engagement and interaction on this. Our next session will be on April 16th, going upstream and digging deeper, the critical role that coalitions play in addressing this national opioid crisis. And we're going to dig a little bit deeper about what are some of the things and considerations for each and every one of you. So I just want you to know that this is a time of fierce urgency in my view. And I'm so proud to be a part of this with all of you. And doing that, I think we stand on the shoulders of great, great leaders who have come before us and have shown us the way. It is my honor to be a part of this journey with you all. Thank you all for going through some of the technical glitches that we had up front. Dave did his checking and he found out that Zoom had an update recently that may have caused some challenges for some of us. And so with that being said, I'm going to provide the closing word to the folks that actually brought us together. I want to give my great thanks to Amber Slater. Thank you so very, very much for your leadership and for what you've done to make sure that this was all possible for us. Give my very dear, sincere regards to Dr. Williams and the like, and to my dear friend Paula. The floor is yours. Thank you so much. Please share everything that you have to share, and you will be the last word.
Thank you, guys. This was a great training. Thank you, Dave. Thank you, Amber. Thank you, Carlton. Thank you, Dr. Hunt, for all the information you have provided today to us about promoting health equity and trauma-informed services throughout our prevention work. This is awesome. Also, we want to thank all our participants to be here today. It's Friday. Hey. We're ready for the weekend, right? And we, like Carlton said, this is a series of trainings. So be ready for the next ones. This is going to be like awesome. The Louisiana Center of Prevention Resources is proud to offer this relevant and timely training for you. If you have any questions, please feel free to contact us at any time through our website or through our email address. So that will be www.subr.edu//LCPR. So we are here for you guys at any time. So have a great weekend and be safe out there.
Hold on, before you all go, Dave put in the chat the website that Paula just mentioned, and we're going to have an after session group for anybody that wants to have a little bit of a chat, an informal chat. There's a Zoom meeting that we just put in the link. So if you want to meet up with us, feel free to go there and we will see you shortly. We're only going to be there for just a little bit, but thank you all so much. I look forward to seeing you all on the other side and seeing you at the next training. Take care.
Thank
and
you,
All right, I'll see you in the Zoom room.
you there.